Good afternoon, everyone. It's a great pleasure for me. Good afternoon, everyone. Anyway, I will start to introduce my topic. I will discuss baits and twin pregnancies, and although twin pregnancies are counted about 2 to 3% among all other pregnancies, they contribute quite a lot because they're very specific in relation to what type of twin pregnancies you are scanning. And therefore, my job today is to discuss with you and highlight several aspects in this respect. I will discuss zygosity and chorionicity. I will make sure you know how to date the pregnancies in twins, how to label the two twins. Then I will go systematically to the different approach in screening policy for most common chromosomal abnormalities. What are the new insights in prenatal invasive testing, and how we would manage twins discordant for any structural defects. And when we start with zygosity and chorionicity, do you think that those two terms are the same? Actually, in clinical practice, what matters is chorionicity rather than zygosity, but let me go with you through what it is zygosity. Well, we have different types of twins, and the dichorionic twins, which means that there are two cells, two ovums, fertilized by two sperms, produce dichorionic twins, whereas in monochorionic twins, we have fertilization of one ovum by one sperm, and it depends of the day if there is a cleavage. We have different types of monochorionic twins, and if the cleavage occurs within the first 3 to 5 days, then we have a dichorionic diamniotic, which means that we have two placentas, two amniotic sacs, and two babies. And if the cleavage occurs within the next 4 to 8 days, then we are having the traditional monochorionic diamniotic twins, which per se means that we have one placenta that is shared with the two babies and two amniotic cavities. And then if the cleavage occurs between the 8 and 13 days after fertilization, then we are having the third type of monozygotic twins, which are monochorionic, monoamniotic. And then the last and the most severe form of monozygotic twinning in terms of splitting is when there is the splitting occurs on the embryonic disc, and this produces so-called the conjoined twins. And now in relation to zygosity and chorionicity, we know that the dizygotic twins are dichorionic, and we know that in monozygotic twins, depending on which day there is this cleavage, we could have a dichorionic diamniotic or monochorionic diamniotic. And now if I want to summarize and take an example, if I take 9 pairs of twins, 2/3 will be dizygotic and 1/3 will be monozygotic. All dizygotic twins will be dichorionic, whereas 1/3 of the monozygotic twins will be dichorionic and 2/3 will be monochorionic. And therefore, all monochorionic twins are monozygotic, and 6 of the 7 dichorionic twins are dizygotic. And let me go with you through the history. Well, this is a picture of Waldo Sepulveda that has been working intensively in the early 90s together with Professor Nicolaides, describing how we can identify the different types of twins as early in the first trimester. And why the necessity came exactly in the early 90s? Well, let me remind you that in the early 90s was the discovery of the nucleotranslucency, the marker that we are using now for assessing the risk for chromosomal abnormalities, genetic syndromes, and many others. And then the 11 to 13 week scan at that time became worldwide accepted, and therefore we were able to identify and see multiple pregnancies in the first trimester. And therefore, in the early 90s, they recognized that the different type of twins could be recognized by ultrasound. And the dizygotic twins, they have the thick separation between the two fetuses, and it's called the lambda cyan in between. And on the right-hand side, you see the T cyan, a very specific characteristic ultrasound marker for diagnosis of monochorionic twins in the first trimester. Now, monoamniotic twins, which were the third type of monozygotic twins, it's also a diagnosis in the first trimester, but remember, to diagnose monochorionic twins, which are monoamniotic, we need to have absence of lambda cyans. Very often we see that the cord inserts very closely to each other, and the same is true that we see the proximities of the two fetuses very close to each other, and we can see the cord entanglement as early as in the first trimester. Now, how we date pregnancy in twins? Well, I will just present you very briefly what we are gonna discuss in the December course in the Viromedicine Foundation organized course in London. And this is actually a new research. How we know and what is known so far? Well, according to the different designated bodies, the different guidelines, we know that in the American guidelines did not specifically address the issue how to date twin pregnancy. Whereas the Canadian guideline says that if the pregnancy is achieved by assisted reproductive technologies or IVF, we should use the day of embryo transfers, and when we have a spontaneous conception in twins, we should use the highest CRL to date the pregnancy. And NICE guideline from the UK recommended that in twin pregnancies, either conceived by in vitro fertilization or spontaneously, we should use the highest CRL. So this is a data that comes from my unit, from Bulgaria, from Dr. Sterev Hospital, that is specialized for infertility treatment. We took 539 twin pregnancies that were achieved via in vitro fertilization, and we found that if we date the pregnancy by the largest CRL, it's overestimate. If we take the smallest CRL, it goes better. And if we take the average CRL, it reduces the variability, and we believe that this is what the approach should be from now on, to have the average of the two CRL to date the pregnancy. Now the next question is, do we need to label twin pregnancy? And the answer is yes. Why? Because when we are doing a screening for chromosomal abnormalities, we need to know twin 1 and twin 2, because, for example, in dichorionic twins, we could have one normal baby and the other one affected by trisomy or any structural defect, and this potentially will guide us through the invasive testing that we are going to offer to the parents. As well, if we want to perform a selective reduction in an affected fetus of the twin pair, we need to know, and we need and must label twin 1 and twin 2, and also in the subsequent follow-up of a twin pregnancy to follow the growth of the two fetuses, we need to start from the very beginning, as early in the first trimester, to identify twin 1 and twin 2, and also to communicate later with the neonatal team. If we suspect any abnormality, then we give the babies to neonatology, and we say them the first baby is normal, but then the second one has been diagnosed, for example, with ventriculomegaly. So this is why we need to know from the very beginning the labeling of twin pregnancy, and at least in my unit we have adopted the policy that the twin 1 is the one that is closest to the cervix, and of course the subsequent twin is called twin 2. Now, going to screening for chromosomal abnormalities, Those are more or less the pictures that you need to save in the records in your centers, in your scanning rooms. You need to obtain the two CROs of the two fetuses. You need to measure the nucleotranslucency in the two fetuses. And of course, the most important thing, and as I started my lecture, is to assess and to know the chronicity of this pregnancy. And now let me go to how we perform screening for chromosome abnormalities in twin pregnancy, and I will highlight in dichorionic, monochorionic, and vanishing twins. And let us start with the traditional method of screening, which per se is maternal age. And in this graph, you can see that if the woman attained your clinical practice and she is at the age of 35, the risk based on maternal age for Down syndrome is the same for monochorionic twins and singleton pregnancy. It's 1 in 250. But if these are the dichorionic twins, you can see that the risk is 1 in 125. And let us assume that we don't have any other way of assessing and performing screening for chromosomal abnormalities apart from maternal age. And if we take this as an assumption, then taking maternal age will classify much more dichorionic twins to be at increased risk for chromosomal abnormalities that will lead to an invasive procedures. Now, what about the second trimester serum biochemistry involving a series of biomarkers, alpha-fetoprotein, free beta-ACG, estriol, and inhibin? Well, for singleton and monochorionic twins, we know that the serum biochemistry has a detection rate at about 70% for a 5% false positive rate. Where we have a problem in dichorionic twins. And why is that? Well, because one baby could be affected with Down syndrome and the other one could be normal. And therefore, if we take a blood from the mother, the baby that has a trisomy will dilute the hormones that are coming from the normal baby. And therefore, the performance of screening, of second trimester biochemical screening in dichorionic twins is very poor, and it has a detection rate only of 40%. Now, let me remind you what we know already. So this is what I have been trying to show you in my live scanning. If you go to the Fetal Medicine Foundation website, you see and you will learn how to obtain the proper measurements of taking nucleotranslucency. And it is 11 to 13 week scan. The CRO of the baby must be between 24 and 84 millimeter. We need to have a mid-sagittal view of the fetal face. The baby should be in neutral position. We should avoid the amnion. We need to put the calipers on tone, and we need to take the largest measurements. Now, how does it apply to a singleton pregnancy? Well, in the late 90s, Professor Nicolaides and his team showed through thousands of patients that has been published in series of studies, has shown that if we take nucleotranslucency measurements, if we take maternal age and we combine them with free beta-ACG and PAPA, we are able to perform a screening for a 90% detection rate, only for 5% false positive rate. And the question is, can we do the combined screening test in twin pregnancies? And the answer is yes. But are there any difference between the different types of twins? And the answer is yes. When we are scanning and we are seeing a dichorionic twins, remember those are non-identical, which means one baby could be normal and the other one could be affected with trisomy. It's different when we are scanning monochorionic twins, which are actually the same, non-identical twins. And if we have one baby with Downs in the pair of the monochorionic twins, it is very likely that the other baby will have Downs too. So how we perform the combined screening test in twin pregnancies? Well, in dichorionic twins, we assess the two fetuses and we give a separate risk for each fetus for chromosome abnormalities. Whereas in monochorionic twins, we scan the two fetuses again, but we give the average risk for the whole pregnancy. And let me show you the graph here on the left. It means that, I don't have the pointer, but I will try to summarize it for you. The graph down there on the left says that in one twin from a monochorionic pair, we could have one baby with nucleotranslucency that it is within the normal range, but the other baby could have a nucleotranslucency that is very much increased. So in order to be accurate, we need to give the average number for the whole pregnancy. And now you ask me, is it the same detection rate as in a singleton pregnancy? Well, in dichorionic twins, for the same detection rate of 90%, we have a 6% false positive rate, which is 5% for singletons, and in monochorionic twins, for the same detection rate of 90%, we have a little bit high false positive rate of at about 9%, and this is mainly because nucleotranslucency is not only a feature for chromosomal abnormalities, but in monochorionic twins, this could be a feature, early feature for twin-to-twin transfusion syndrome. And just to summarize it, in dichorionic twins, we give separate risk for each fetus, whereas in monochorionic twins, we give the average risk for the pregnancy. And let us say that if we have one baby with very much increased nucleotranslucency, and the risk for this baby is 1 in 4, and the other baby has a nucleotranslucency that is within the normal range or less than 95th percentile, and the risk for this baby is 1 in 1,000, then the risk for that pregnancy will be 1 in 8. So bear in mind, average risk for chromosomal abnormalities in monochorionic twins. What about cell-free DNA testing? And when I touch the topic of serum biochemistry in providing as a screening test for twin pregnancies, I highlighted that there is a problem because the blood from the abnormal baby could dilute the blood of the normal one. And the same, or we are having similar effect in performing cell-free DNA testing in twins, because the placental mass, the source of cell-free DNA from the normal fetus, may be bigger, and this could potentially mask the trisomic fetus. So bear this in mind. What is the literature evidence? How accurate we are to say to our patients that the cell-free DNA test is working? Well, we know, and you have heard from many congresses and many Zoom meetings, that it's brilliant for a singleton pregnancy. It says that the detection rate for Down syndrome is 99.7%. But what about twin pregnancy? Can we be so confident to say to everybody, have a cell-free DNA for twin pregnancy? And this is a meta-analysis that has been published by my good friend Mark Gill together with Professor Nicolaides. So they had a summary of 13 studies publishing on the use of cell-free DNA test in twins. And what it sees, or what you can see in the table, it's on 137 cases of trisomy 21, the detection rate with cell-free DNA is 99%. So pretty much a very accurate test for screening for chromosomal abnormalities. What about trisomy 13 and 18? And you can see that for trisomy 18 we have only 50 cases, and for trisomy 13 we have only 11 cases. From this meta-analysis, it appears that the test is good, but we are not so confident to emphasize it as a first-line screening test. Now, what about vanishing twin? What does that mean, vanishing twin? When you do a scan at 11 to 13 weeks, you see one normal growing baby and the other one has died, and it has an appearance of an empty sac. This happens at about 2% at 12-week scan, and the question here is, can we offer to our patient presenting with a vanishing twin the use of cell-free DNA as a screening test for Downs? And the answer is no. The literature so far suggested that the DNA that comes from the dead tissue and the dead placenta, and remember, in the vanishing twin, by definition, we do have one fetus that has died, produce cell-free DNA in the subsequent 15 weeks. So the test could be potentially false positive, false negative, and therefore it's not recommended to be offered as a screening test for chromosome abnormalities at 12-week scan. Well, can we use the combined screening test? And what does that mean, the combined screening test? To use the ultrasound measurements of nucleotranslucency to combine them with maternal age and with the biomarkers. This is a study that it was a collaborative project between my unit in Bulgaria and King's College Hospital in London. And what we have identified is that in a case of a vanishing twin, you can use free beta ECG and combine it with the nucleotranslucency and maternal age. But unfortunately, the levels of Papae were increased, and therefore we don't recommend to be included at the moment in the screening for chromosomal abnormalities. And what is the summary of that? Well, if we take a singleton pregnancy and let us say we add free beta ECG and Papae, the detection rate will be at about 91%. But if we measure nucleotranslucency and add only free beta ECG, we will go up to 86%. We would accept the detection rate is a little bit less, but at the moment, the evidence are suggesting that we cannot use Papae. What about invasive prenatal diagnosis? This is the latest research that was performed with the Fetal Medicine Foundation. We know that there is a twofold increased risk having a chorionic villus sampling in the first trimester for pregnancy that were identified as a high risk for chromosome abnormalities. What about structural defects in twins? I will take a few more minutes. I think that this is important. You have heard very nicely this morning Professor Aris Papageorgiou trying to teach us what are the most important things that we need to acquire as a knowledge to assess the anatomy of the fetus as early as 11 to 13 weeks. And the question here is, can we do the same in twin pregnancy? And is there any more common structural defects that is related to twin pregnancy? And the answer is yes. In dichorionic twins, the prevalence of structural defects is 1.3%, whereas in monochorionic twins it's a little bit higher, and this is mainly because there are specific defects that are related to monochorionic twins, such as trap sequence or conjoint twin pregnancy, but the detectability of defects is the same as in a singleton pregnancy at 11 to 13 weeks scan. Now, what about having nucleotranslucency discrepancy or CRL discrepancy? If you measure nucleotranslucency and it is above the 95th percentile, this is per se an indicator to look thoroughly through the whole anatomy of the baby, because this study from the group of Singilaki showed that in 70% of the twins that have a nucleotranslucency above the 95th centile are more likely to have any structural defect, and the same was true if we take a CRL, a discordance between the two babies more than 10%. Now, if we have one normal baby and the other one is affected with trisomy or any structural defects, and we cancel our patient of selective termination, what would be the benefit to identify all these problems as early as in the first trimester? Well, even though this study is coming from Mark Evans from the 1994, it's the best study that shows us what are the numbers. It means that if you do a reduction as early as 12 weeks, you are having at about 5% risk to have the pregnancy loss, but you're reducing the rate of preterm delivery. And it's not the same when you have a selective reduction at 20 weeks, because you are increasing the rate of miscarriage. Remember, the bigger the baby, the bigger the dead tissue, and therefore the rate of miscarriage is increased. I think that it's an important figure that all of you need to take picture. This is a summary of a very big study showing us what are the most common complications in pregnancy and why it's so very much important to identify chorionicity, to have a proper counseling of the patients, to require and store images of CRL, nuchal translucency, and to have a thorough anatomical check in the two fetuses. And I thank you very much for your attention.